Welcome to Variations 4, the shock unit. And in this video, we'll cover questions 9 and 10. So question 9, contrast the 3 stages of shock. Just looking at your concept maps here. So this would be map number 5. I know it's a bit messy, but straight out of the text. So, in early shock, your compensatory stage, it's what you probably most commonly think of when the body's able to compensate. So, for example, for most of the shocks, not neurological, of course, neurogenic shock, this wouldn't apply to. In cardiogenic shock, it may apply to, it may not, depends what's going on with the heart. But generally speaking with shock, we think, okay, if blood pressure drops, then heart rate's going to go up. That's an example of a compensatory mechanism. Another compensatory mechanism is that blood vessels will start to constrict in certain key areas to try to raise up pressure again and increase perfusion. So you may have some selective vasoconstriction going on that may or may not be effective in your compensatory stage of shock. So when you progress on, you get to that progressive stage, things are getting worse. Your compensation is not working as well, might be ineffective, and the obviously your perfusion goes down. Permeability of the capillaries is something we've talked about throughout this whole units, and I mean that can really happen at any stage of shock, but it gets worse if the inflammation gets worse. Inflammatory response gets worse. If the shock progresses further and you get into here your refractory stage, you can have total decompensation in terms of your heart just might stop altogether, or blood pressure is really dropped low in terms of fluid having gone to tissues. You also still get this vasoconstrictive response, but the problem in the refractory stage is that the vasoconstriction is, for lack of a better term, not logical. Your body's over vasoconstricting and actually cutting off blood supply to certain areas. There's a point when it just stops being helpful. And I think I summed it up here in your notes as well, in class questions. Or there it is there. Selective vasoconstriction occurs in shock as the body tries to increase perfusion to key organ sites. But in the refractory phase, this constriction is more widespread, but is not helping to increase perfusion. In fact, it might actually be cutting off blood supply to certain areas now. So that in a nutshell is your 3 stages. If I was to sum it up, I'd say shock is, as we've talked about throughout the whole unit, many of them, some kind of loss of blood, loss of perfusion, compensatory mechanisms like the heart, vasoconstriction. And the further along you get into these stages of shock, the more ineffective these compensations mechanisms are, and the more they break down. Again, heart could completely give out, and again, vasoconstriction becomes disorganized and inefficient, ineffective, and may even do more harm. All right, 10, the 2 paradoxical problems with DIC. We talked about this already. It's excessive clotting and excessive bleeding because your coagulation factors are being used up. So you've got it all right here. And coagulation factors used up, PT9R become elevated, platelets become decreased as they're used up in clotting as well. So Xigris was a med that was mentioned in an earlier edition of the textbook, but it's been updated since then. It's not used. It can increase your bleeding risk. It's really tricky because you want to, at the one hand, you want to help clots break down, but on the other hand, giving something like heparin to help clots break down also increases your bleeding risk. So how do you treat this? It's a balancing act between the clotting and the bleeding. And on the other hand, you may want to give something to increase coagulation, such as blood products, such as fresh frozen plasma. Maybe it has coagulation factors in it. But then you're increasing thrombi formation. So it's totally this teeter-totter balancing act here.